So, moving on, in chapter 15, it talks about the 5 P's. And so, we do need to think about these critical factors that are going to help or hinder labor and delivery. So, we're going to start off, first of all, by talking with passenger. Then we'll move with passageway powers, position of the mother, and then psychologic process of labor. So, when you think about the passenger being the fetus, we need to think about the size of the fetus head. The one benefit of the fetal head is that the head does mold. The sutures of the cranium or the plates are not fused together yet during fetal life, and so that does allow for molding, which does help with the fetus being able to pass through the birth canal. So when we talk about anterior and posterior fontanelles, when you're doing when you're doing vaginal exams, those are going to be things that you will be feeling for with your fingers. So being able to palpate where those fontanelles are and determining the location of the passenger. And then with the molding, molding will be present on most vaginal deliveries after on the fetus's head, and that molding does tend to go away after about 24 hours. But when you see a fetus that has or a baby that has a molding to their skull, those are kind of the ones that they talk about, like having a cone head, or you're able to see the overriding sutures. And so those are just a couple of different things about the fetus's head. With fetal presentation, we need to think about what is that presenting part. So we need to think about if it's cephalic, meaning head down, head first, breech, which could be a footling, or it could be double footling, or just a frank breech or breech presentation with their buttocks coming first, and then a shoulder presentation, which would kind of go along with the transverse lie, which is right a few lines below that. So with shoulder presentations, transverse lies, those types of babies aren't obviously going to probably be delivered because of the fetal lie, fetal presentation. When we're looking at fetal attitude, it talks about being vertex, which means that basically the head is down, the chin is tucked onto the chest. When you think about a military, think about the military officer saluting and how straight and forward facing their head is, and then brow would be just kind of a sniffing position. So the eyebrows are kind of the presenting face, and then a full face presentation is just exactly that. The face is coming first. When we talk about ROA, LOA, LOP, those are talking about fetal position in relationship to the mother. So when we think about ROA, that is right occiput anterior, and so it's the fetal position is really determining how that fetus is positioned in the pelvis and which direction their face is in comparison to the mother's body. So the fetal presentation is the relationship of the fetus to the mother. These are just a couple of different photos of those presentations of the passenger that we just kind of talked about. So here you have your shoulder, a frank breech, which means the feet are up by the head. Full breech is that the legs are tucked in, but the bottom is still coming first. And then singleton is when one foot comes out. And if you have a double footling, then obviously that's going to be both. So this A is really your best case scenario where the baby's head or chin is tucked, and they will do some external rotation once they are delivered. So here is the ROA, LOA, when you refer back to this slide when we were talking about fetal position. With fetal position, so again, it's in relationships to the mother's pelvis. So posterior, meaning in the back, so this would be toward the buttocks. Anterior, obviously, is toward the front. So you're looking at the fetus's spine in relationship to mom's pelvis. And so when babies are born, physicians will usually tell you what that position is, but if you miss that and you are helping deliver, you should be able to see when the baby's head comes out, like in this ROA position, the head will come out, and then the baby will be, the baby's spine is to the right. So it's the position of the fetus's spine, not the fetus's face. So we're looking at the fetus's spine in relationship to mom's pelvis. When we talk about station, this was one of the very first pictures that we talked about. And remember, when we're talking station, the negative numbers means the baby is higher up in the pelvis. With those positive numbers, that means the baby is coming down nicely into the birth canal. A +4, +5 is going to be a fully, the head is being delivered. When we talk about engagement, engagement means that the baby's head is nice and descended into mom's pelvis, and when it's not blottable, you as the provider, you as the nurse, won't be able to push up on the baby's head and move it out of the maternal pelvis. And so engagement is really, really important when we're talking about rupture of membranes, because if a woman has a rupture of membranes and this baby's head is not engaged in her pelvis, then we run the risk of having a cord prolapse, because the head can follow the rupture of membranes, or not the head, I'm sorry, let me go back up. The umbilical cord can come out with the gush of membranes or with the rupture of membranes, and then you're going to have a prolapse cord, which if you have a prolapse cord, then she needs to move immediately to C-section. So we like to see infants' heads engaged. Typically, physicians will not rupture a bag of water until that head is engaged, just because of the significant role it does play with prevention of cord, with a prolapsed umbilical cord. Again, just another pictorial view of fetal station. Same with this. And this is a really cute one, +4 on the floor. So just remember, positive is really, really good when we're talking about stations. So passageway. Passageway, we need to consider, what is mom's pelvis like? What is the bony pelvis like? What are the soft tissues of the perineum like? How is that going to play a part with delivery? And so when you're looking at this, this is table 15.2, this picture right here. It's table 15.2, page 383 of your textbook. And when you're looking at this, typically what we like to see is a round or the gynecoid. And typically that's what we see most women having. There's a very small percentage that have the platyploid, and that just really, if you see the platyploid type of pelvis, oftentimes chances of delivering vaginally are going to be kind of slim. So we like to see pelvises that do have some type of shape to them, so that does ease, help ease with the delivery of the fetus and being able to have that mom deliver vaginally. And truly, in that first prenatal visit, when the physician is doing the initial pap and pelvic exam, what we see is the physician spending some time palpating around those soft tissues, palpating the ischial tuberosities, feeling what that pelvis really feels like, and kind of helps give them a little bit of an idea of maybe what they can be expecting to occur with that delivery. When you're thinking about powers, we have two powers, primary powers. That primary power are related to the contractions, and contractions help cause the effacement and shortening of the cervix, and it also helps with dilatation. So contractions that are effacing and dilating a cervix during the first stages of labor, that's going to be your primary power. And then the secondary power is contractions as well as mom pushing. And the secondary powers come with the second stage of labor. So the secondary powers are really those powers that mom utilizes along with her uterine contractions to help deliver that baby. So this is a cervical dilatation chart, and you can see that we start at 0 to 1 centimeter right here, and then complete dilatation is 10 centimeters. And we will bring in a couple of cervical charts so you can actually feel those with your fingers and kind of get an idea of how those numbers change and the position of your fingers, things like that. And then we need to talk about contractions. And so when we talk about contractions, really the thing that you need to be aware of is the increment is the increasing or the building of strength. The peak is obviously the highest or strongest point of intensity, and the decrement is then that contraction coming down or decreasing in intensity. When we talk about duration, duration is how long is that contraction lasting. So when we talk duration, duration is from start to end. When we talk about frequency, frequency is just a little bit different because frequency also includes that uterine relaxation time. So when we're talking about frequency, it's from start of one contraction to the start of another contraction. And so the duration is typically charted in seconds, frequency is minutes, and that's kind of the difference between the two. So when we're talking about frequency, again, like I said, it's that time from the beginning of one contraction until the beginning of the next. The duration is the beginning of one contraction to the end of the same contraction. Intensity, when you're using intensity or thinking about intensity, we chart that or discuss that being mild, moderate, or strong. And so when you think about mild, and you're palpating if a contraction is mild, moderate, or strong. When you're palpating, if you take a second and take your finger and kind of push on the end of your nose, that would be a mild contraction. There's really not a lot of resistance. It's kind of soft, but there's a little firmness to it. When you think about moderate, then push on your chin. There's a little give to that, but it's much more firm than what your nose is. That would be the palpation of a moderate. And then strong, if you take your fingers and palpate your forehead is very hard, it's very firm. And so that would be ways to think about describing contractions. With contractions, if you absolutely want to know the intensity of them, remember you have to have that internal monitor in. Otherwise, the only way to determine true intensity is by palpation. Remember that external fetal monitor is only going to talk about frequency and duration. And then interval is the amount of time that the uterus relaxes between contractions. And the interval is very important because that's when our baby's getting reperfused. That's when that perfusion is getting better to the umbilical cord, to the placenta, and then again to the fetus. So interval or resting period is really important part of contractions. So here's just a picture image of everything that I've talked about. And again, these pictures are posted on Doc Sharing. When you think about the position of the mom, we really would like our mom to be moving as much as possible. Definitely do not want her laying flat on her back because that will cause hypotension, decrease perfusion to the fetus, and just won't produce good outcomes. So if we can, let's have her make frequent position changes. Let's get her one side to the other. If she has an epidural, maybe sit her up straighter, move her around a little bit. If she has not had the epidural or intrathecal and she's still able to ambulate, let's get her up. Let's get her walking. Let's get her to the chair, maybe on the birthing ball. So taking consideration of getting her up and moving, it just puts pressure on the cervix in different places and really will help enhance delivery, because when she's up and moving, she has that feeling, maybe a sense of control that she can help with this pain versus just laying there in the bed and taking the pain as it comes. And your psychologic response, when you think about your psychologic response, that's your entire being. So you need to think about what mom is perceiving. What is she seeing going on? How are her emotions? What's her mental state? Is she able to communicate, or is she so out of control due to pain or the effects of labor? Can we get her calmed down? Can we get her on the right course for delivery? You also need to, think about the cultural diversity that you're going to encounter. And again, I've spent a lot of time in class when we first started talking about cultural diversity and cultural beliefs and differences. So really make sure that you have a good idea of what your patient's values are. What does she and her significant other, her support person, want to see happening throughout the labor process. As far as the physiologic effects of labor, physiologic, that is, again, your fetal heart rate, circulation, respirations. So when we're looking at the fetal heart rate, we talked about the normals and we talked about the accelerations and decelerations. Fetal circulation, as I just stated, is affected by maternal position, affected by uterine contractions, affected by blood pressure. It's all of that all of those perfusing factors. And then fetal respiration, remember from earlier we talked about how the fetus doesn't really breathe, but once the baby is born and it has those stimulating factors, then we're going to see chemoreceptors in the aorta and the carotid bodies that are going to enable that fetus to breathe. I'm going to stop here and I will continue on with objective 65 again.